Hello, everyone. The Latin American team from the Young Epilepsy section, or JES from the ILAE, we are pleased to welcome our speaker of today's webinar, Professor Aristea Galanopoulou from the Albert Einstein College of Medicine. Professor Galanopoulou is an MD PhD. So she got her MD degree in Athens, Greece, and her PhD at McGill University in Canada. Dr. Galanopoulou is a professor of neurology and neuroscience and director of the Laboratory of Developmental Epilepsy at the Albert Einstein College of Medicine. She's a chair of the Neurobiology Commission of the ILAE and co-chair of the ILAE AES Joint Translational Research Task Force and editor-in-chief of Epilepsy Open. Her lab investigates mechanisms and treatments for epilepsies across the lifespan, with a special focus on infantile spasms and post-traumatic epilepsy. Dr. Galanopoulou received the ILAE Ambassador for Epilepsy Award in 2015 and the Saul Korey Award in Translational Science and Medicine in 2017. For today's webinar, Dr. Galanopoulou is presenting the EEG findings in acute ill patients with COVID-19, which is a very interesting and trending topic. So the learning objectives for today's webinars, which are endorsed by the ILAE Academy, is to determine who should receive EEGs, be familiar with sensitivity and specificity, and how to interpret the report in the clinical context. Also to recognize and describe interictal abnormalities, to recognize and describe ictal patterns, to appropriately diagnose all types of convulsive status epilepticus, including differential diagnosis, and to appropriately diagnose all types of non-convulsive status epilepticus, including EEG interpretations. So without further ado, I'll leave you with Professor Galanopoulou.
Thank you very much, Pablo, for the kind invitation and for the opportunity to discuss some of the more recent work that we have done that was not prompted by the long-standing research that we do in the laboratory, but from the recent experience that all of us have had with COVID pandemic. As you very well know from your own work and from your own lives, this pandemic has changed a lot of the ways that we normally conduct our work, the interest that we have, and it has triggered a lot of new directions in research, but also different methods in practicing as clinicians. And a huge explosion in the literature. So what I will describe today is the experience that we had at Bronx in New York with the cases that we had admitted in the hospital with COVID. I put the graph on the top of the slide to indicate the wave of COVID-19 cases that we had in New York. And as you very well are familiar, that was one of the epicenters of the COVID-19 pandemic, particularly during the March and April period. The good news about that is that we have, for the longest, as we were discussing with Pablo earlier on, reached a nadir. So it's very low number of cases, and we have sustained that. So the describe pertains mostly during the peak of the pandemic when we had many patients admitted to the hospitals. Hospitals were converted to COVID centers as in many cities across the world. And in the EEG department of Montefiore Hospital, we had started to accumulate some experience with EEG studies. I put down, it's an interesting surge that although COVID started a few months ago, there has been an explosion of studies relating to this experience. And if you do the search by COVID-19, SARS-CoV-2, for the year 2020, you can actually find 45,960 cases in PubMed. And on top of that, there is a huge number of publications that appears in preprint servers. And that indicates the importance of learning more about the disease per se, the neurobiology, and trying to think about how can we translate that not only in better and safer practices in the clinic and in the hospital, but also possibly developing treatments for this disease. The respiratory and systemic symptoms of COVID had been very well known since the beginning, because that was a known fact that it starts as typically fever, cough, shortness of breath, pneumonia. But over the course of few months, it was that we started to realize that neurological manifestations are actually a very significant component of the disease. They may not happen in all of them, but a range of vague neurological symptoms, and sometimes not so vague, and serious neurological complications and manifestations appear. And today what I will focus mostly is about the epileptic or seizures and how the EEG can be used to inform us a little bit more about what is going on during the acute illness. So there is a need to develop better tools and safer tools, I would say, to minimize exposure of the clinical of the personnel, to improve the early recognition, management, and the prognosis of the affected patients, as well as provide insights on the neurobiology of the disease. And EEG studies have provided a useful tool to gain some insight on the potential impact of the virus and parallel pathogenic processes triggered by the infection on brain function and the proneness of the brain to manifest epileptiform activities or seizures in acutely ill hospitalized patients. There was an article when the virus started coming to New York. There was an article that triggered a lot of interest that I read, and that was titled "The Neuroinvasive Potential of SARS-CoV-2 May Play a Role in the Respiratory Failure of COVID-19 Patients." And it's an interesting review or opinion paper that brings along some new ideas that for us who do neurology research and epilepsy research are very intriguing. So it started commenting on the emergence of neurologic signs in hospitalized patients with COVID that may vary from headache, change in mental status, and sometimes they become more severe, more focal strokes, hemorrhagic complications. And there was a precedent from other coronaviruses that they may actually invade the central nervous system. And there was an evidence from humans and also from animal models. I will describe some of that. And the authors proposed that it might be that due to a potential neuroinvasive potential of the virus, that may be a factor that could contribute to respiratory failure, potentially through affecting brainstem nuclei or nerves that are important for the cardiorespiratory control. So that was a very intriguing proposal. And they also referred to 2 case reports of the COVID-19 where they detected the virus in the CSF of patients with meningitis and encephalitis. And one was from China, the other from Japan. These were web reports from hospital. The Japanese case, I will present it to you later in the next slide. And this basically prompted some interest to see, could it be that the virus causes that decline and the severity of the prognosis partially because it can invade the brain. It has been discussed and cited a lot, and this is the case from the patient from Japan that was the first case of meningitis encephalitis associated with COVID-19. That was a 24-year-old man with headache, fatigue, fever, sore throat. On day 9, he developed altered consciousness, seizures, neck stiffness. The nasopharyngeal swab, interestingly, was negative for the virus. Eventually, however, they found confirmation through the CSF, cerebrospinal fluid, when they did the spinal tap. And the MRI showed an abnormality at the right mesial temporal lobe that you can see in the circles here. There was no EEG reported, And that was one human evidence that there may be cases when the virus can intrude into the CSF and potentially CNS, causing minicoencephalitis. There have been coronaviruses before COVID-19, obviously, and there's been a few studies in animal models investigating the neurobiology, what is the effect of the viral infection in the brain. And Netland and colleagues published in 2008 an interesting paper where they used mice transgenic for human angiotensin converting enzyme 2 receptor, which is practically the receptor through which COVID, the virus, can enter in the cells. And what they did is they gave the SARS-CoV virus intranasally through inoculation, and they looked to see whether that can actually spread and diffuse into the brain. And indeed, when they looked at the histology, as you can see in the brainstem sections and hypothalamic sections, SARS-CoV can actually give a signal at both of those regions as opposed to the naive animal. And they noticed death of the animals in a significant number of animals, and they postulated that this probably may result from dysfunction or death of infected neurons, especially those in the cardiorespiratory centers of the medulla in the brainstem. They proposed that the spread in this case is olfactory bulb, and then they saw a spread to the cortex, including piriform cortex, infralimbic, and also in other regions like the basal ganglia and even the midbrain. So that provided a proof of concept that the potentially transsynaptic route of transmission or spread from the olfactory area or bulb to the brain could be feasible, and therefore it could be a concern as we deal with patients that are infected. Less consistently, the spread happens through the thalamus, hypothalamus, amygdala. Obviously, this is a little bit difficult to translate in terms of the load of viruses in this animal model as opposed to the usual infection that humans have. And it is also true that not everybody develops such severe neurological problems after the COVID. So it is not as simple as that. This is just a demonstration that this is a possibility. But what may facilitate that or make certain individuals more vulnerable, it has not been identified yet. They also report an interesting finding that the virus causes minimal cellular inflammation despite the widespread infection. However, they do see a prominent pro-inflammatory surge of cytokines and chemokines in the brain. So that there is inflammation, not so much cellular, and they did provide some evidence of spread through the olfactory bulb to the brain. This is a nice review and a figure from a review by Cataldi on the neurobiology of coronavirus that presents potential routes for entry into the brain. And one possibility is what we discussed before, the transsynaptic route through peripheral or cranial nerves. The second possibility is blood-brain barrier permeability disruption from the viremia, meaning that if you have the peripheral infection in the lung, for example, and viremia, that can, the interaction and recognition of the ACE2 receptor by the virus in the endothelium can prompt the entry. The inflammatory process or cytokine storm that also coexists may precipitate that. So that may facilitate potentially entry in the brain. And on top of that, we also know that another feature which is very interesting of COVID infection is the coagulopathy that can potentially contribute to vasculopathy or vascular complications, strokes, or hemorrhagic. And that may be another way of breaking the blood-brain barrier and entering into the brain. A final route that has been discussed is the lymphatic route, and that's a point of interest. that recently has been investigated more as to the importance in various diseases. The first study that highlighted the incidence and the prevalence of neurological symptoms and manifestations in COVID-19 patients came obviously from China. And it was the study by Mao. Initially, it was published in a preprint server and eventually at JAMA Neurology. That was a report retrospective on 214 patients with COVID-19. And what the authors describe is 36.4% of them actually had neurological manifestations, whether these were in the central or peripheral nervous system. Those with severe COVID-19 illness, meaning more severe respiratory status, they had more neurological symptoms, 45.5% as opposed to 30.2%. And this, it should be noted that that includes both central and peripheral. So whether some of them could be, for example, critical illness, neuromyopathy, or peripheral neurology, this is one component of this. Acute CVAs, cerebrovascular accidents, were seen in 5.7%, and in subsequent studies, this percentage also holds approximately there between 2 to 6%, depending on the cohort that is reported. Impairment of consciousness in 14.8% as opposed to 2.4%, and skeletal muscle injury 19.3 versus 4.8. So any type of central neurological system symptom can be seen in 24.8 patients. It's not statistically significant, this trend, 13 severe, 20 non-severe, but it's still significant overall to consider. Seizures, interestingly, have not been so common in this cohort. Only 2 patients, meaning 1% manifested, and whether that could be a reflection that people who get into a hospital with symptoms, they get better treatment, and we do have the anticonvulsant and anti-seizure medications available. So the fact that there was no overt seizure seen could be a reflection of more early treatment. This is a possibility. And subsequent studies cover some of the other studies that describe EEG or seizure abnormalities in them. But overall, this is a minority of the cohorts for many reasons. This is another cohort from France in this case. This is 58 patients, and what Helms and colleagues reported, they used a cohort of severe COVID-19 disease, and these are ICU patients, and all of the patients had confirmation of the virus by nasopharyngeal swab. Agitation was noted in 69%, confusion in 65%. So the significant CNS mental state signs of disruption. Interestingly, in 33% of discharged patients eventually manifested dysexecutive syndrome, meaning inattention, disorientation, poorly organized movements, which speaks for some sequelae of CNS impairment. MRI showed leptomeningeal enhancement in 8 of the 13. Bilateral frontotemporal hypoperfusion was seen in 11 out of 11 patients, which is worth keeping in mind in view of the findings that I will discuss later. And that was done through perfusion imaging, suggesting of dysfunction in the frontotemporal area. EEG was done only in 8 of them, and that showed bifrontal slowing consistent with encephalopathy. They did not see or report any epileptic activity, but obviously these findings here suggest for some level probably of focality in a subset of these patients in the frontal lobe region. What is also interesting is that CSF was negative for SARS-CoV-2 in 7 out of 7 patients. And this is going to be a kind of recurrent theme in many of the few studies that actually sent some reported samples on CSF, that although there may be CNS manifestations, it's really very challenging and difficult to document the virus in the CSF. We can discuss it later on. This may not necessarily be perceived as absence of CNS infection, but it may be other issues as well. But that also demonstrates the challenge of using what we like to use as term objective diagnostic tools to confirm CNS disease in this case, because the sensitivity may not necessarily be as high. And that's one of the reasons that prompted us in our study to look at additional diagnostic tools to see if we can identify CNS involvement in some of those patients. This is another cohort from China by Dongzhu, Lulu, and colleagues that they reported on 308 COVID-19 patients with negative prior history of epilepsy. And they were looking to see whether how often they see new onset acute symptomatic seizures in or risk factors for seizures in people who are admitted with COVID-19 infection. So overall, 27% had brain insults, which is in alignment with other studies that I discussed earlier. And those brain insults could potentially predispose to seizures. 2 patients only, however, which is 0.65% had seizure-like events attributed to stress or hypocalcemia. And there was no evidence suggesting an additional risk of acute symptomatic seizures in people with COVID-19. Neither the virus nor the potential risk factors for seizures seem to be significant risks for the occurrence of acute symptomatic seizures in COVID-19. So overall, that was a little bit of quietening in the sense that as epileptologists, we may not need to worry that much about seizures being a major factor. However, this did not stop us from investigating. One of the reasons is because EEG studies had not been done systematically in China, and partly the reason is understandable because for us who are faced with the request to do an EEG in a patient who has COVID-19 infection, there is a concern as to unnecessary exposure of healthcare personnel if there is no significant gain in the management of the patient. So deciding as to whether it is worthwhile doing an EEG in these patients or not, and if yes, what is the safest way, it is very important in improving the management. So this brings us to the study at Montefiore that we did, and this is all my colleagues in the EEG department that contributed in the study through reading EEGs and collaboration in this specific retrospective study. So what we started to do is the key question that we had is what is the type and prevalence of EEG abnormalities in patients with acute COVID-19 positive illness. And we decided to restrict that only to medically indicated EEGs. Partly that is a practical aspect because that's a retrospective study. But also going forward, as we were thinking of doing a prospective study down the road, it would be a little bit challenging to decide to do a prospective study using EEGs without taking into consideration the safety component and the exposure risk of technology, so personnel who applies the EEG electrodes. So the questions that we had, is there evidence for significant rates or specific EEG patterns of epileptiform or other EEG abnormalities in COVID-19 positive patients? And can the EEG inform on potential brain dysfunction insulted by the virus, direct or indirect? The inclusion criteria included people that were admitted at Montefiore and had EEG studies done. They had COVID-19 suspected presentations, and this is important. So as you can see, in the cohort that we try to include, we include people who had COVID-19 testing done, and the testing could be either positive or negative, and we made the decision to do that so that we can have a comparison group of COVID-19 negative patients to compare the findings with, and see if we can get any conclusions about specific effects of this particular virus as opposed to other conditions that trigger similar presentations on admission. And the EEG studies that we reported in the paper were mostly cerebral study. I'm not sure how many of you are familiar with this, but this is one of the different types and brand names of rapid EEGs. This is a headband EEG that contains 10 electrodes and provides 8 channels of EEG. The advantage of this, as opposed to the 1020 system, is that it is very easy to apply. It does not require a technologist. It can be done very promptly, and it can be done by healthcare personnel, for example, that take care of the patient. So you minimize exposure of technologists, and you do the study within minutes rather than waiting for an hour or two to request the study, have the tech place the electrodes. And in this particular case, it was convenient because it minimized the exposure to the virus. The patients had to be admitted between March 1 and April 15, and that coincided with the peak of the wave in New York. And we compared positive versus negative COVID-19 patients, and these are the specific conditions for the cerebral recordings. It is typically an assembly of frontal, temporal, and occipital electrodes. Obviously, it lacks parasagittal, parietal, and more localizing electrodes, but it covers broad areas that are commonly affected during seizures. Sampling up to 50 hertz, low frequency 1, high frequency 30, and there is flexibility to range between 0.1 hertz to 100 hertz. In addition, some of those patients eventually did have routine EEGs or continuous EEGs, so we reported on those too, and there were 2 additional routine EEGs that we added. So this is the cohort. During this period, we had 22 patients that were positive for COVID-19, as opposed to 6 patients that were negative to COVID-19. That already highlights one of the challenges, because if you are operating at a time where you have the big wave of the virus, you're biased to have a lot of positive patients, not so many negative. And that has limited most of the statistical comparisons that we did. But nevertheless, it allowed us to identify some interesting trends that I will follow up and discuss whether other groups also have found them. And that was the main reason that we published the study as preliminary reports, because we wanted to communicate a finding that we were very interested in having more investigations going after them and see if we can cumulatively improve the level of knowledge that we have about this condition. So we included mean age was 63 versus 57. It was strictly all of them were adults or older than 30 years of age. Gender was pretty much split. 63.6% were males, a small preponderance of males. Past medical history, only 18.2% had epilepsy among the COVID positive, none of them in the COVID negative. Another factor that limited the study, but it's practically the nature of doing good medicine is you have to treat a patient promptly, and you don't wait for a study necessarily to confirm if you need to treat. So many of those patients were already on anti-seizure medications because of suspicion for seizures, for example, or suspicion that the altered mental state could be because of an epileptic condition. And this is reflected here. So 86.4% of the patients, the COVID positive, were already on sedatives or anti-seizure medications, either because they were intubated or because of seizure prophylaxis or control. And that may reflect obviously on the incidence of epileptic activities that one can detect. Many had prior neurological conditions or psychiatric conditions. The main indications for the EEG were rule out non-convulsive status epilepticus, and you will notice that almost uniformly, pretty much all of the EEGs, with only two as an exemption, were done to rule out non-convulsive status epilepticus. So the aspect of poor mental status that I will describe a little bit more later on is a significant trigger for a request for EEG and for evaluation by an EEG that you cannot bypass. A significant number had motor seizure-like events or seizures at presentation or confusion episodes that resembled prior seizures. So these were seizure-like events overall, and that we saw in almost in half of the COVID-positive patients, and in 16.7% of the COVID-negative. So regardless of what the EEG will show, as I will describe later on, clinically, many of those people had seizures, and many of those people who had EEG had already received anti-seizure medication for those. Confusion at presentation was seen in 4.5%, case deviation 9.1%, and these were also indications for EEG request. And as I mentioned, sedatives or anti-seizure medications were quite common. This is a breakdown per respiratory function. As you're going to see, the black part of the pie here is intubated patients. The orange is people who had respiratory distress but were managed by cannula or high flow or non-rebreather. So the vast majority of both cohorts had significant respiratory dysfunction. The distribution of renal versus liver dysfunction was pretty much even in COVID positive versus COVID negative cohorts. And obviously, as we all know, the presence of metabolic abnormalities is a significant factor for EEG abnormalities. And that's the reason that we also looked at that. Eventually, we did not see any association of the findings that we had with presence or lack of any of those metabolic abnormalities. The two cohorts were different, statistically significant different in terms of whether other infectious pathogens were identified. And as you're going to see here, the COVID-19 negative cohort, the vast majority of them had other infectious pathogens identified. That is 83% of them as opposed to 24%. So there is a difference between these populations. The reason that I'm mentioning that is that, as all of us know by now, having a test for SARS-CoV-2 that by PCR that is negative does not necessarily confirm the absence of the virus infection in a patient. And this is the first case report that I described by Moriguchi is a good example that the virus was not detected peripherally in the nasopharyngeal swab, but it was detected in the CSF. And we all had the experience that repetitive tests may be needed to confirm. So this is a limitation in the comparison, but regardless, we do see that there is a difference in regards to the etiology, infectious etiology between the two. Indications for EEG studies, it's a busy slide, but the main point is that there's a significant number of patients, as I mentioned, that came with seizure-like events, almost like half of them. And the encephalopathy, meaning new encephalopathy, was seen in 68.2% of the COVID positive cohort versus 33% in the COVID negative. And there were very few, only 2 COVID negative patients, 1/3 of them had seizure-like events. So the altered mental status and the seizure-like events are common indications for EEG that make the value of EEG more eminent. What we found on the EEG was quite interesting. Before I go into the findings, I have to clarify that the cerebral study, the headband 8-channel EEGs, allow for continuous EEG monitoring, not in terms of the several days period of time, unless you apply them repetitively, but allow us to record the EEG for several hours. So we had a range of 190 to 375 minutes of EEG running as a mean for each of the patients that we recorded. So it's more than the routine EEG that lasts typically for 20 minutes. So that allowed us to sample longer periods of time. And what we found is that there is a sporadic epileptic abnormality identified in 40.9% of people who had COVID-19 positivity, as opposed to 16.7%. It's not significant, but it's a trend that is intriguing to follow up. And what is more interesting is that 8 out of the 9 patients with COVID positivity had frontal sharp waves on the EEG. And I'll show you some examples in the next slide, suggesting some kind of predilection for the frontal lobe. And you remember that in one of the previous studies, I commented on the fact that there was a frontal lobe dysfunction by some of the diagnostics that they did and the symptomatology. Additionally, we found generalized or frontal rhythmic delta activity, which has been reported in many studies after this in the EEG, in 13.6% by frontally sharply contoured periodic waves, in 4.5%. These are non-specific findings of encephalopathy. And seizures, we did not find any on the EEG of those patients. However, as I mentioned, many of those had seizure-like events at presentation and had been treated for that. So potentially the fact that we did not find could be because these are treated patients or sedated patients that aren't under investigation. And this is a breakdown regarding to whether the presence of sedatives or anti-seizure medications affected the distribution of sporadic epileptiform discharges. In this case, the distribution of sporadic epileptiform discharges in people without prior history of seizures. And you see that 39% of those that came with COVID positivity had new epileptiform discharges from the EEG, as opposed to 17% in the COVID negative. The presence of renal dysfunction or liver dysfunction did not give us any, in people who did not have renal dysfunction and did not have liver dysfunction, we still saw epileptiform discharges. So they cannot just be explained by the metabolic abnormalities. And these are examples of frontal sharp waves. You can see an example here on the right frontal. This is one of the patients who had 1020 EEG routine that you can see a frontal sharp over here. And here is a spike again on the frontal. So these are 3 different patients that gave us this kind of pattern. So overall, what we found from this is that new onset encephalopathy is a common reason, 68% versus 33% in the COVID negative, prompting EEG investigation in COVID-19 positive patients, and therefore investigating those patients for underlying causes, EEG by EEG, is a valuable approach. We just have to make it safer. Suspicion for clinical seizures and or EEG evidence of epileptiform discharges are common in COVID-19 positive patients. Seizure-like events were common at presentations, 54.5% as opposed to 16.7%. We interestingly found a signature of frontal sharp waves as the predominant epileptiform discharge focus in almost 89% of the COVID positive patients, as opposed to 16.7% COVID negative. we did see generalized with adult activity, although that was not the predominant pattern in a minority of the patients in both cohorts. This is an example that limited coverage with quick application EEG systems like headband EEGs may indeed offer an alternative to minimize exposure to the virus, but also gain information that could be useful for the management of the patients in this case. There's many limitations, obviously, and we discussed this in the paper that we published in Epilepsy Open. There's very few COVID negative patients. Comparisons of positive versus negative is problematic sometimes because of the false negative rates that we may encounter. But still, if we increase the numbers with large cohorts, that can be a way to adjusting and being able to compare people who have similar presentations. So we need to have bigger studies done to evaluate this. 8-channel EEG provides a useful tool in the COVID setting. Also the fact that this is based on clinical reports of many EEGers, and it's a retrospective study. And I'll present a little bit of the literature to see is it only us who see this finding, or have there been any other reports subsequently to raise an interest about this frontal focus. So this is an example by Flamand and colleagues, was published in Clinical Neurophysiology. 80-year-old woman, respiratory distress, fever, altered consciousness, focal motor seizures with left leg clonus, worsening mental status, CSF MRI were unremarkable, metabolic tests were actually within normal levels, including ceftriaxone levels. And what they found is that they saw bifrontal sharp waves that you can see here, repetitive initially, and as it progressed, it evolved into periodic triphasic waves in the absence of other metabolic abnormalities, also supporting that the whole setting of COVID-19 infection may actually have triggered this. And by no means, neither in our study nor in this study, I imply that this is a direct effect, but it's just information that we collect to start building future studies to determine what is the main trigger and pathogenesis for these epileptiform abnormalities. In the study by Socchetti from Italy, they reported cerebral involvement in COVID-19 as associated with metabolic and coagulation derangements. They used EEG. They found they reported on 18 patients with neurological manifestations in COVID. Transient loss of consciousness was seen in almost 28%, seizures 28%, delirium almost 17%, coma 28%. The intubation rate was a little bit lower than ours, 33.3%, and 44 died. The EEG findings are interesting. Very few had epileptiform discharges, only 2 out of 18. Mostly it was generalized background slowing, which was also a uniform abnormality in our study as well, 88.9%. And interestingly, they saw anterior prevalence of slowing, more prevalent in moderate to severe EEG abnormalities group versus the mild EEG abnormalities group, and that was significant. And the moderate to severe EEG abnormalities group tended to have EEGs done at later times and in the intubated people. And the hypoxia was linked with more severe EEG abnormalities. And here is a breakdown that you can see that more severe EEG abnormalities are more prominent in people who have risk factors like hypoxia or metabolic abnormalities. In the Vespignani cohort, 26 patients with COVID-19, again, they used a limited coverage EEG, very similar, not the same as our study, investigating mental status changes, poor responsiveness, seizures, and status epilepticus. So as you can see, there's always a need to use EEG for many of those indications. Slowing, they found in 73%, isoelectric in 7.7%, They describe generalized periodic discharges in 19%, and they describe generalized rhythmic delta slowing in 5 of those patients with maximal at the frontal area. And the authors discussed that the 5 who had periodic discharges consisting of frontal high amplitude monomorphic delta waves, and you can see some nice examples in these EEGs, with absence of epileptic activity may suggest injury or localized brain defect attributable to encephalopathy related to unique and acute CNS process. And here I summarize in a table several case reports that reported on COVID-19 patients with seizures and had EEGs done on those patients. And what we can see is that in many of those, you see frontal bilateral, anterior, frontal bilateral, frontal right, midline, and left frontocentral. This is a little bit more broad, frontal, central parietal, right or left, right frontal, anterior abnormalities. So we're not the only group. There's many other groups. Definitely, there are reports also of foci that are not strictly frontal, but these raise a lot of interest in whether the frontal lobe could actually be one of the sites that could become vulnerable. And we're thinking, as we think about the fact that there is a sore throat, some people come with anosmia, there's a lot of congestion, and obviously that route of entry is highly suspicious and raises the question as to whether the two might be linked to some extent. There's a few studies, two that I found that did FDG PET to identify changes in signal in COVID-19 patients. So this is one study by Karimi Kalugahi that describes a 27-year-old woman, right-handed, with 6 weeks of anosmia, COVID-19 positive, and in the PET study under neutral conditions, meaning odorless room, they identified reduced uptake at the left orbitofrontal cortex, as you can see here. And there is another interesting study by Delorme and colleagues who reported 4 patients with encephalopathy related to COVID-19, and they had conducted FDG PET CT in these patients. So these are adult patients who had encephalopathy, frontal lobe impairment. 2 of them had cerebellar syndrome, 1 myoclonus, 1 psychiatric manifestations, 1 with status epilepticus, and the EEG showed frontal or anterior abnormalities in 2 of them. FDG PET showed frontal hypometabolism and cerebellar hypermetabolism in these patients. MRI did not show any abnormalities. CSF, no significant abnormalities. And interestingly, again, it was negative for SARS-CoV-2 virus, 1 responsive to IVIG, 1 responsive to steroids. And the authors proposed in this case a para-infectious or post-infectious immune mechanism as contributing to this picture, both the clinical frontal lobe impairment, the imaging, and also the EEG abnormalities. This is another study by Scullen and colleagues on encephalopathies and cerebrovascular disease from New Orleans. They report on 27 patients critically ill with neurological manifestations, and they separated them in 3 subcohorts. One was with encephalopathy, 74%. There were 2 patients with acute necrotizing encephalopathy, 7%, and vasculopathy, 19%. And the EEGs that were done in these, in 13 of those patients showed either diffuse slowing or nonconvulsive status epilepticus. There is no specific localization for this. Obviously, the message that I try to convey is not that there is one way of thinking. And yes, there is it raises a lot of interesting questions that we do find in a significant number of our patients, the frontal lobe dysfunction, sometimes with epileptogenic, epileptiform activities and discharges, and sometimes as focal slowing or abnormalities in diagnostics. But this by no means it can be extrapolated that this has to apply globally, particularly as we think of the multifactorial pathogenesis of CNS dysfunction in patients who have COVID-19 infection. For example, in the Prevalence case series that was published recently by Lewis and colleagues, they reported on 22 patients with COVID-19 positivity who had EEGs for altered mental status and seizure-like events similar to our study. 19 of them had continuous EEG for days, so that was one difference from our study. That was a little bit more prolonged than the few hours that we reported, and more global coverage in the brain, 3 routine EEGs. The majority of them were intubated, 82.8%. Majority were on fentanyl, propofol, midazolam, and among the 19 continuous EEG studies, what the authors describe, 4 out of 19 had epileptiform abnormalities. 2 of them had already prior history of epilepsy. In those with prior history of epilepsy, they found generalized polyspikes and right frontal sharp waves, and we cannot attribute that to necessarily COVID because that was presumably pre-existing. Undetermined epileptiform discharges in those without prior epilepsy. I could not find the localization of those events. 2 out of the 19 had seizures, but no prior epilepsy. And in these seizure events, they describe a right centroparietal in origin in one of them, and in the other, left more than right frontotemporal and left parieto-occipital foci at onset. They describe generalized periodic discharges in 36.8%, 5 with triphasic morphology, 2 with sharply contoured waves, and 52.6% had generalized rhythmic activity. So it's probably one of the highest rates of the GERDA that is described in COVID patients. And in 1 out of the 3 routine EEGs, there was a seizure, left hemispheric rhythmic activity associated with that. They did not find any association with outcomes, although understandably this is, as most of the published case reports right now in case series, only based on 22 patients that we need more information to know. So that also speaks for the heterogeneity. Yes, you're going to have people who have foci in other regions, particularly if they developed stroke or a hemorrhagic lesion or coagulopathy or a hypoxic insult. But it's still very interesting that you have several reports independent, just describing frontal dysfunction and sometimes epileptiform potential. And the reason that we eventually try to do those studies is not only just to acutely manage the patients that we have, but get some clues to see as to what can we do to translate these findings to better treatments or new treatments. And I'm giving an example here. It is a case report, but it is a nice graphic representation of, for example, a way that one could imagine practicing in the future. 60-year-old male, altered consciousness, irritability, confusion, asthenia, fever, cough, cognitive fluctuations, presented with severe kinetic syndrome with mutism, could not carry out simple commands, palmomental, glabellar reflexes, moderate nuchal rigidity, increased D-dimers, which is common, CSF, pleocytosis, lymphocytic, negative again for SARS-CoV-2 or other viruses. EEG shows generalized slowing, theta, unrevealing, unspecific. And what the investigators did is they decided to treat with methylprednisolone that is also used in many sites at this time. And this shows the course of the patient after the initiation of the steroid treatment, with improvement in the clinical course and eventual normalization of the EEG from that. So as we go forward, I think we have to try and make some line of thinking or strategies to take this kind of heterogeneous clinical data and clues that come in specific cohorts of patients, and think as to how can we investigate those cases more in more detail to gain some insight about potential treatment and potentially kind of individualize the approaches or rationalize the management of the patients. And this is one of my last slides. It's a very nice review and perspective published by Elul and Tom Solomon recently, Neurological Associations of COVID-19. And they took advantage of a registry that many of the COVID patients with neurological and psychiatric conditions are being registered through physicians to log the various neurological abnormalities in COVID-19 patients, as well as reviewed the literature. And what they report in the literature and in their knowledge that there are 93 cases of encephalopathy so far, 8 of encephalitis, Guillain-Barré 19, common signs is anosmia and ageusia, loss of taste. Cerebrovascular disease ranges between 2 to 6% in patients with COVID-19. SARS-CoV-2 in CSF has only been identified so far in 2 case reports that I mentioned in the beginning, and it has been cultured from an autopsy in 1. So one of the messages, many people have done lumbar punctures and CSF, but the identification of the virus in the CSF is extremely difficult to get, and it may be that it doesn't go there as often, which is good for us to know that may limit the toxicity of the virus. But the other possibility is that it may invade the CNS, but because of the low dilution, it may be very difficult to identify in the CSF, and this is something that has to be clarified in the future, because the message is it's not to convey that you have to stop sending CSF for the virus, but we really need to see what is a more effective way of diagnosing CNS dysfunction and insult due to COVID-19, directly or indirectly, and how can we use that for the treatment. The table is also very interesting to see, and I prompt you to read it in the full review in the Lancet. So they start with the experience with SARS and MERS, and they basically, based on the known prevalence of the different viruses, they extrapolate the numbers of COVID-19 patients that one would expect to see based on the prevalence of each of those viruses and the percent of the different neurological manifestations. So what they say here is that COVID-19 worldwide minimum case count based on this huge number of infected individuals up to the point that they were writing the review. If we extrapolate the data from the experience from SARS, you would expect to have 1,805 patients with CNS, 2,407 patients with peripheral nervous system disease deficits, and 4,213 patients with neurological disease. That's an average, so it's a very large number. So even if the neuroinvasiveness is not as effective as to affect every human being, even in the low prevalence that we anticipate based on the previous experience, the numbers of individuals that will be affected far exceed the few numbers that are reported, and it's significant enough to try and improve the clinical care that we do. So in conclusion, increasing awareness of neurological manifestations of COVID-19, central and peripheral, is important and has been incrementally done over the last few months with the multitude of reports that are emerging. EEG reports in acutely ill patients demonstrates background abnormalities that are non-specific, slowing, rhythmic delta, periodic discharges, and in some patients, epileptic abnormalities, including in patients with no prior history of epilepsy. There are reports of frontal dysfunction or epileptiform discharges in COVID-19 patients with encephalopathy or seizure-like events, raising the question of spatial susceptibility of this brain region, either to the virus or to the parallel systemic pathogenic processes that are ongoing. More studies are needed. Other foci have been reported and will be reported probably due to the multifactorial nature of the disease. And more studies are needed, large control blinded to validate, as well as studies to identify the mechanisms underlying these findings. And the last message for the clinical practices, although because we try to operate in a safe environment, there are ways that people can do now, EEGs, to minimize the exposure of the healthcare personnel to the virus, including those new headband EEGs that can give you remotely, can allow you to remotely read the EEG and provide a diagnosis. And just to acknowledge the group of physicians that have worked with me in the Department of Neurology and EEG division of the Albert Einstein, and I do not have any commercial conflicts or stocks to the company that provided the 8 channels, so there is no conflict of interest in terms of the findings that I present here. Thank you very much.
Oh, thanks so much for this fantastic presentation, Aristea. It was great. So we have a couple of questions from the audience. So the first question that we have is: are there any reasons for COVID-19 spreading to frontabasal regions other than the close vicinity with the nasal structures? And could it be maybe because of any sort of molecular affinity with neurons or glia from that area?
So that's an excellent question. Obviously, the hypothesis and the explanations that we try to give is based on what we know. And what we know is the vicinity and the neighborhood of the nasopharyngeal cavity to the brain and the cranial nerves that provide a route for entry. But this is a key question. And actually what it does, it accentuates the need to do more, I would say, investigations into the pathology of COVID. And there's not so many reports in terms of the brain autopsy specimens or brain pathology to identify. So this is actually very critical to do. Number one, to demonstrate whether there is virus in the brain, because right now we have only 3 reports of CSF, or 2 reports of CSF presence of virus, 1 in an autopsy, but there is no systematic approach to prove it. And that's really critical in terms of differentiating whether this is a direct invasion as opposed to indirect via the blood-brain barrier or cytokine or a slew of other metabolic entities. So that's a very important question to follow up in the future.
Thank you. So just following up on that line, could it be an effect of higher inflammatory cytokine production seen these severe COVID cases with the development of seizures?
It could be. Obviously, as all of us know, there's a very high interest in the interaction between the inflammatory and immune processes and ictogenesis and epileptogenesis. So this is and many of us have done research to that effect to show that there is a facilitation of seizures and sometimes trigger of seizures in many models. So yes, there is. In terms of the studies that we have, the number of seizures in the population that we have, as I described, is not so much yet. So there's few reports of seizures, and most of them have already been treated with anti-seizure medications. And there's few reports that studied steroids or IVIG, for example, to try and minimize the inflammation or immune component, and they describe an overall improvement in the clinical course in the people who respond. Not everybody responds, but in those who respond, yes. What would be interesting is to eventually get an insight about the results of the clinical trials that are done, because there are some, for example, clinical trials on interleukin-6 monoclonal antibody, the receptor, or other anti-inflammatory drugs, and look and systematically report the neurological complications and see what is actually the effect of those new or existing anti-inflammatory drugs that we give on the course of the neurological manifestations and the outcome. So that again is a very important question to follow up with more research, and it also prompts for encouraging a systematic kind of registration of those patients so that we can probe those kind of databases and data and get some insight about outcomes and potential new therapeutics.
Mm-hmm. Thank you. And also, I think you mentioned that Piloto's study, they use I think an steroid drug, and they saw an improvement of these abnormal EEG patterns. But in your cohort, did the LPDs resolve with any steroid drug use, or including dexamethasone?
So we have not. So right now, for this the preliminary report, we did not look at that, because you have to understand that the beginning of the pandemic is actually a little bit probably not the best way to do retrospective studies, because there were a few clinical trials ongoing. There's people who are recruited in different clinical trials. There's different numbers of medications that are given at different time points. So this is not probably the best setting to address. We are doing a larger review of the data that we have with much larger number of patients. And probably, hopefully, this is going to allow us to at least differentiate some medication effects on certain outcomes on neurological findings. And obviously, the other important element is the collaboration with the existing clinical trials of the investigative drugs, because there's a few of them, multi-center trials. It would be good eventually to get some information from them about what is the impact of those drugs, not only on the days until discharge, but also on the neurological outcomes and long-term outcomes of the patients. So these are ongoing efforts that we have to look for in the future.
So I presume that they, or at least from your cohort, I'm not sure if someone else has followed the EEG so if someone else has followed the EEG on these patients, and whether they have followed also any changes in the cytokine levels at different time points after the recovery, or is that part of sort of?
So when we're looking at the data that we have from this small cohort, there are data on cytokines, for example, D-dimers, and a bunch of the usual markers that we basically look for the COVID-positive patients. When you look at the COVID-negative patients, you can hardly find anybody have them. So in terms of comparing how much is that a random fluctuation or a drug effect, you really need large numbers and controlled populations. And ideally, the way to go would be to plan for a prospective study, to have a controlled environmental comparator groups to make a dissociation. Because even if we find, two of the interesting questions would be, what is the role of inflammatory markers or immune system in the pathogenesis of COVID-19? And is that really so much different compared to what we know from other viruses that affect humans? Is there something specific about COVID-19, or is it just the high, contagious kind of nature that makes us think more alarmed and careful about this? But otherwise, the neuroinvasive or impact on the CNS is not that bad. So we're planning to do some retrospective and prospective, probably studies to see if we can get an insight, more definitive insight into those.
Mm-hmm. And I think just the last question, there's still more questions, but I think in the interest of time, do you see or has anyone reported any evidence of behavioral changes in patients with that have been reported with PET abnormalities in orbitofrontal regions?
In orbitofrontal, yes, there are some reports, and actually I also prompt you to a study that was published by Delon. I think I had a slide on this, that they reported 4 patients who had a frontal lobe syndrome at presentation, and they found FDG PET abnormalities and some frontal dysfunction. So that was actually one of the interesting kind of clinical and diagnostic associations in terms of the frontal lobe dysfunction. And some of those patients interestingly responded to IVIG or steroids. So it's an interesting study, but coming at the end of the day, I agree that it's very critical to try to tie in the presentation of the patients that we get with COVID-19 to the various laboratory abnormalities and see if we can gather some clues to have a more strategic approach to developing better treatments and management.
Thanks, Aristea. And if you allow me to ask you one more question, because there's been a bit of discussion here in the chat. Is there any evidence of patients that are undergoing chronic neuromodulation with COVID-19 infection, whether they're having an increment in their seizure frequency?
There is not much evidence, but obviously there is a lot of interest to investigate this aspect. So the long-term outcomes of COVID-19 is a key, because these are things that will impact down the road. So there are ongoing efforts to investigate that. So I don't, it's a little bit too soon to tell, because the pandemic started a few months ago, and looking at long-term, we already have come to realize that there is lingering effects of COVID-19. But when we talk about long-term outcomes, we need really to follow up those patients in the long run to see what is going to be the long-term outcome, whether this is epilepsy, whether this is other neurological dysfunctions. So it's really important for us to keep having an eye on those patients.
Okay, well, yeah, it was very, very interesting, your talk, Aristea. It was fantastic, and I think there's many of things to look forward in the future and to learn from this devastating disease. So thanks again for joining us and for sharing your presentation. And then please, I'll remind everyone to join in and fill in today's evaluation, that you will have the link in the description of the video below. And please stay posted for our next webinar in the next week. And thanks again, Aristea.
Thank you very much, Pablo, and also for the very stimulating questions of the audience. It's really something that the whole community has to start to continue talking. I mean, that's going to be an ongoing discussion. So thank you for organizing this.
Okay. Thanks, everyone. Thanks, Aristea.